It is my distinct pleasure to introduce Dr. John Diamond, who's professor and head of child and adolescent psychiatry at the Brody School of Medicine, Department of Psychiatry and Behavioral Medicine, East Carolina University. He's also the medical director of NC Start East. He is one of our NCAHEC liaisons, and he's a telepsychiatry consultant for SURF Pediatrics in Dare County and Goldsboro Pediatrics. He is certified by the American Board of Psychiatry and Neurology, Psychiatry, and the American Board of Psychiatry and Neurology in Child Psychiatry. He received his medical degree from Howard University in Washington, D.C., and did his fellowship in child and adolescent psychiatry at Western Psychiatric Institute and Clinic at the University of Pittsburgh. He has over 38 years of clinical experience as a child psychiatrist in Eastern North Carolina. So please welcome Dr. Diamond. Thank you, Dr. Diamond, for being here this evening.
Thank everyone for coming, sharing some of your evening with us. So what I'm going to try to go over today is discuss kind of an overview of ADHD, some of the effects on the child and the family as it affects more than just the child, review some of the aspects of the diagnosis, and then discuss the current treatments. So to begin with, just I'm going to go through this a little quicker because this is sort of some basic things I think everybody's pretty familiar with, but the DSM-5 categorization put ADHD in the neurodevelopmental disorders away from the disruptive behavior disorders. So it used to be along with oppositional, defiant, and conduct. Now it's in its own separate section. You also have to consider intermittent explosive disorders when you're looking at ADHD, and you always want to consider disruptive mood dysregulation disorder among some of the things to consider looking at the DSM-5 with similar symptoms. So to begin with, we'll end the controversy now. Is ADHD overdiagnosed? No. You can make a case to say sometimes it's overdiagnosed, sometimes it's underdiagnosed, but in this grand scheme of things, it's not an overdiagnosed condition. Scientologists claim we're drugging children. We aren't. If it's genetic, why does it persist in the gene pool? You can make a case to say that maybe it was adaptive to our hunter-gatherer ancestors, and it's no longer so adaptive, but it persisted because it tends not to lead to death, so it doesn't breed out of the gene pool in a sense. You should think of it that way. Do more children have ADHD now than in earlier times? That's probably not, because if you read back in history, although nobody talked about ADHD in the past, you can find even in a quote from someone in BC times, describing the kids sounding very much like he's describing ADHD kids. So the historical timeline that we know of is described in the 19th century literature. In 1918, this pandemic we're going through now, and we had a similar pandemic about 100 years ago, which led to von Economos encephalitis. In children, it looked like actually that some of them developed what sounded like so-called hyperkinetic syndrome or ADHD, while some of the adults developed Parkinson's disease. What's interesting about that is that this virus that caused mayhem 100 years ago, it seemed to affect the dopamine system, but for adults, if you deplete the dopamine system in certain parts of the brain, it results in Parkinsonism, while it seems like in kids, the dopamine isn't functioning properly in other parts of the brain. So it's an interesting link, even though nobody really understands that well. In 1902, the syndrome was first described as ADHD, and this was by a group at Johns Hopkins started describing some of this. But there's obviously very limited literature that's available to read about it. By 1930, it began to be called minimal brain damage. And the reason for that was that there was a general sense that if someone had a brain injury, it could either be intellectually disabled, maybe traumatic brain injury. There was oftentimes hyperactive behavior associated with it. So the reverse reasoning went, if someone with brain damage can look hyperactive, and someone with hyperactivity must have brain damage. So that was the thinking even leading to the so-called minimal brain dysfunction in 1960. It wasn't until 1968 with the DSM-2 that hyperkinetic reaction appeared. Then in 1980, we got the more current, closer to the current nomenclature of the DSM-3 with ADD plus or minus hyperactivity. It became ADHD with the revised version, and finally in DSM-4, attention deficit hyperactivity disorder. And then it was in 2013 with the DSM-5 that was placed in neurodevelopmental disorders. So the diagnostic criteria per DSM-5, some symptoms present before age 12. That's new, and that's relevant only because we don't tend to think of this as a late onset condition. But I think that was added in DSM-5 because lots of times you can't get a good early history, and you don't want to deny the diagnosis when it's blatant because you don't have the good history before age 5 or 6. So it became a little more liberal in the age, but I don't think that means that you could see someone for 10 years who has no evidence of the disorder and then suddenly develops it maybe at age 11 and a half. That would be unusual. There should be impairment in 2 or more settings. This isn't new for the DSM-5, but it's new for American thinking in that when it first came out, I think with the DSM-3, there was talk about impairment in 1 setting. And it was actually the British that recognized you really need to have more than that. And the British tended to diagnose conduct disorder a lot more frequently when we diagnose ADHD. And I think we've converged on this a bit more by us recognizing you don't just diagnose it because you're hyper in 1 setting. There needs to be a little more going on. There should be evidence of clinically significant impairment. So it's not just hyperbehavior, but there's impairment, as is true of all disorders. And it's not a result of other disorders. And I often say that ADHD is very hard to rule in. In many ways, you've got to say nothing else is causing it. And it makes sense that it's ADHD because everything looks like inattention. If someone is depressed, they don't pay attention well. Somebody's anxious, they don't pay attention well. Something if you're psychotic, you don't pay attention well. So no matter what's going on, it may affect attention. So you've got to kind of be sure in a symptom survey that other things aren't happening before you kind of rule in this idea that they have ADHD. And then there's the subtypes, the predominantly inattentive, the hyperactive impulsive presentation, and the combined presentation. The significant thing about hyperactive impulsive is that that might be more for preschool kids where you can't diagnose inattention as easily. So this is 6 or more of the following inattentive symptoms. Sometimes I add daydreaming, even though it's not one of the criteria, because I think it's a fairly useful item that goes along with this. These kids are very forgetful. They often lose things. They daydream a lot. One study said that a lot of these kids have a slow cognitive tempo. The problem is nobody can define how to really measure a slow cognitive tempo, so it's not really included much. But it's an interesting literature to read about that concept. Impulsivity and hyperactivity then have these symptoms, which I won't bother reading. 6 or more of these also for the impulsive and hyperactive type. It's important to recognize, though, that when you have ADHD, there's often comorbid conditions. So these kids will often also have a conduct problem, oppositional defiant disorder, anxiety disorders, mood disorders, learning disabilities. The MTA study, which we'll talk about in a little bit, found actually that maybe no comorbidity was in about 1/3 of the cases. And that's relevant to how they looked at this, I think. But again, the important take home is that a lot of these kids have some kind of comorbid condition, so you're not just treating ADHD alone. How does this affect parents? Well, when a child has ADHD, the parents can begin to worry. Part of that might be because the kid is getting thrown out of daycare, they're calling from the school. It affects the parents' employment. Yes, there's a lot of anxiety that develops in parents. There's also a lot of frustration because they don't feel like they know how to be good parents. The kids don't listen, they're impulsive. You think you've tried to provide consequences and they're not very effective, and that leads to anger. Lower self-esteem, blaming themselves, more social isolation. Nobody wants to come over and play with their kid. Their kid can't go over to somebody else's house. That can lead to depression in the parent. And if the parent is anxious or depressed, that just sort of is a catalyst to make the child's disorder that much worse. You can make a case to say sometimes that if you don't treat the parent's condition, you'll never be able to treat the child's condition alone. So the parent is a key part of how the child is feeling. And if they're not doing well, this isn't going to help. So I said there's increased employment disruption, which is really sad when you find out how parents are saying they can't leave work because they'll be fired. Kid is not making it in school, and it's a real problem. Marital disruption, as you can imagine, how that causes marital conflict, and that'll often lead to increased alcohol and substance use. So this is a disorder that isn't simply, well, they don't do well in school, give them a little bit of medication, help them in school, and we're all done. This is a much bigger condition and affects a lot more of the whole ecosystem that the family lives in. And what about affecting the kids? Well, besides getting in trouble all the time, It limits their academic growth because they don't pay attention, they don't learn well. Kids don't want to play with them, so their relationships are impaired. It leads to low self-esteem. There tend to be more accidents. They're accident prone at times with the impulsivity. There's even been evidence of increased motor vehicle accidents when they start to drive. More substance abuse and smoking, certainly more legal problems, and then potential occupational problems as they grow up. So it can be a lifelong problem, and it affects them throughout development. Some of the biological correlates that are interesting. These are pretty old studies that were done, but nothing has really changed to make these obsolete. The Danish did xenon inhalation studies, looked at perfusion in the frontal lobes and the striatum, and they found that using this method, that the frontal lobes and the striatum indeed had low vascular perfusion, so they're not oxygenated well, they're not functioning as well. And certainly the frontal lobes that was looked at a lot, and you can certainly think about when the frontal lobes aren't functioning, you get impulsivity and poor executive functioning. So this kind of was a biological correlate. PET scans, which uses radioactive glucose. Now, that's not done as much, that can't be done in kids, but in the 90s, it was done at NIH with a bunch of adults who had a good history of ADHD. And they found the same thing, low radioactive glucose utilization, which you need to be radioactive to get the positron emission scanning, low rates in the frontal lobes, the striatum again. So again, more evidence that something is going on in those areas. MRI studies have found possible asymmetries of the caudate nuclei, and again, differences in the frontal lobes. So there's a lot of different methods of measuring that are all pointing to the same area. And then finally, quantitative EEG. I had actually done some work on this myself many years ago, looking at slow wave activity in the frontal lobes. And there does seem to be some compelling information on this. The problem has been it isn't really well, it's hard to replicate well. And nonetheless, there is a company that somehow got FDA approval. I'm forgetting the name of it now, but they received FDA approval to be able to do this in your office so that you can quickly attach a few electrodes and get a quantitative EEG and diagnose ADHD. And it got FDA approval, but I don't think the science is quite there yet. So, you know, when I say that, say the science isn't there, what that means is that you're going to get false positives and false negatives. It's not that slam dunk that, hey, this is here and they've got the ADHD. So it's very interesting from a research potential. And again, it seems to be the same areas that are affected biologically, but nothing has really panned out to how we can use this very well in an office setting diagnostically. With the exception, I said, the FDA did approve that quantitative EEG method, which is kind of curious. ADHD then is a clinical diagnosis. We don't have these sophisticated biological studies, so just, you know, it'd be nice to say, wow, they've got this slow waves in the frontal, you know, we've got a biological measure to say they've got this. We don't have it. There's no test for ADHD. Everybody tends to think there's some sort of test, and parents will say, my child needs testing. Teachers will say, get your child tested. If there's some kind of magic test that we can do that's going to diagnose ADHD, we don't have it. Psychological testing tends to support ADHD, but it doesn't diagnose it. There's plenty of false positives and false negatives. There's no laboratory measure, as we've said. The rating scales are not diagnostic instruments, so we can use rating scales to measure change, and I think it's more effective. So if I have somebody who has ADHD, and we do some intervention, and then we have a baseline scale, we can follow progress on the scale, which might be a teacher rating scale or a parent rating scale. But as for diagnosis, again, they're not that good. They have very good negative predictive power. Generally speaking, if a teacher says there's no evidence on the scale that the child has ADHD, you've got something like a -8, like a 98% chance of being correct if there's no ADHD. But when the scale suggests there is ADHD, you're dropping down to a positive level of maybe 78%, depending on the scale. So there's a lot of false positives. So again, they're useful, but they're not useful to say yes or no, this test shows you have it, and that's it. Finally, drug response is not diagnostic. We have a tendency in the field to be pragmatic at times. I don't know, maybe they have ADHD, it's kind of an unclear diagnosis, they're not doing well, let's go ahead and give them some Ritalin. Well, you're lucky if you get a slam dunk response. You say, you know, I gave them a dose of Ritalin and bam, it's like magical change. So, okay, that was nice and helpful, but The problem is these drugs have a non-specific response. Everybody gets a little bit better. If you have a rating scale and you measure them pre and post Ritalin, you'll find everyone's better. This was even done by an NIH study back in the 70s, where an IRB would never approve this in terms of human rights, but they gave a bunch of normal, kids that were not diagnosed. I hate to say were normal. A bunch of kids who were not diagnosed were given dexedrine and in normal and so-called regular classes. So of course, in a regular class, there's got to be a couple kids who had ADHD by the statistics. Well, the teachers rated the class uniformly better when the whole class was getting dexedrine compared to when the class wasn't getting dexedrine. So there is clearly a non-specific response, and you can't just say, oh, every one of those kids had ADHD. If you get a response, if you give somebody 5 milligrams of a starting drug like Ritalin, and they don't get better, now what do? You say, well, that was a low dose, let's try a higher dose. But what if the 20 milligram dose doesn't work? Do you then say they don't have ADHD? No, you can try Adderall. So again, if you don't have the diagnosis, you can't rely on the drug to make it, because some kids don't respond to the drugs initially, whatever you try. So that's just a caution. Be careful using that as a diagnostic tool. So the big MTA study, the multimodal treatment, it was a multi-site study done in the 90s. So it's really dated, except this is a great study. It's quoted all the time, and really nothing has superseded it. 14-month trial, 579 kids had ADHD, and they were randomized to one of 4 treatments. Medication management, which was very structured management. They went in, I don't know, maybe let's say monthly, they go in to get the medication titrated, measured. Maybe they use a rating scale to show improvement. Behavior management, which was just behavioral therapy with no medication. Combination therapy, and then a community-based treatment. And I mentioned the structured medication management because community-based treatment was kind of treatment as usual. Whatever they get in the community, kind of as a community control. It could be as good as medication management, but could also be seeing the kid once every 3 to 4 months with medication titration. The results were shocking to the field, because although combination therapy was marginally better, medication management was clearly quite good. And this through child psychiatry as well as psychology in a tizzy, because up to that point, child psychiatrists were kind of haughty. We all kind of said, you pediatricians that just give everybody Ritalin, you don't get it. You're missing a holistic treatment that needs to be done here. These kids need more than just medicine. Well, the response to medicine alone was pretty robust. So we have to kind of eat crow in many ways. And the combination therapy was better, but was it that much better to justify going through all the trouble of getting them a therapist and paying for therapy? So then the psychologists responded, this isn't right, because they believed in therapy treatments. The behavioral treatment was really low. Well, lo and behold, remember those comorbidities. Those comorbidities are high. And what came out of this essentially was that, yeah, medication management was quite good, but it doesn't treat oppositional defiant disorder. It doesn't treat anxiety. It doesn't treat depression. It doesn't treat conduct disorder. So there's a role for behavioral treatment. There's a role for combination treatment. So that's kind of what came out of the study in the end, after lots of controversy and rethinking. The number needed to treat is a statistical measure, epidemiological measure that people don't use much, but it's a really useful measure. It essentially is the number of people that receive a medication or any intervention in order for just one person to receive a benefit. It's a scary term because when you realize that the number needed to treat isn't very high for most conditions. So if you treat somebody for hypertension, you might get a number needed to treat of 8 or 10, which means you're not getting much effect despite using all these medicines. And it humbles medicine to realize our treatments aren't nearly as good as we think they are, but they sure are for ADHD, which is really kind of interesting. Number needed to treat for medication is 3, which is about the best you can find in the field for any medication we use, for anything. It's a really high number. The drugs are quite robust. And behavioral treatment, 11 isn't bad, considering other treatments in medicine, but alone, that's not nearly the effect of medication. And of course, both being a little better than medication alone. So remember, it's a clinical diagnosis. It's based on the DSM criteria. It's a developmental disorder. So There is some literature. People try to talk about, well, there's maybe an adult onset ADHD, and we're looking at kinds of different areas this way, but nobody has really come through to say that it is nothing but a developmental disorder. We have no strong enough evidence to say you can have had no ADHD through your 30s and then at age 40 develop ADHD. There's just no good evidence for that. And the likelihood seems to be that if you develop what looks like ADHD at age 40, it's probably anxiety or depression or something else that's appearing your attention. Or it was just recognized late. That happens too. It's not that it's developing late, it's that it was recognized late, but to say you had no symptoms before that is pretty unusual. And then remember that medications have nonspecific effects. It's more important that the diagnosis precedes treatment. If you're not confident about the diagnosis, you're going to go around throwing drug upon drug upon drug, perhaps with the wrong condition. And just to mention briefly ADHD in adults, it's challenging because of that developmental history isn't available. It's really important to get a developmental history. And so if you can, we'll even tell the college students if you can talk to your parents, it's that much better. Of course, once they're over 18, they don't have to give that permission. But without that information, we don't know what's going on. And there's a lot of drug seeking on campus. There is many rating scales. One that I'm mentioning is the Wender Utah rating scale, was an attempt to get childhood information. It has pretty high sensitivity, and some say more false positives. But I said these things are not really diagnostic. So if you can get an adult's early condition history, that's really helpful. When you can't, it's much harder to diagnose this in adults. You've got to be aware of, again, the comorbidity. And inattention is hard to diagnose. And adults will more often present just with the inattentive piece, which is harder to quantify. So it's the harder diagnosis to make. Okay, so classes of ADHD medication. The FDA-approved drugs include the stimulants, the norepinephrine reuptake inhibitors, of which there is now 2. It used to be just atomoxetine, and the alpha-2 adrenergic agonists. So this is like Ritalin and Dexedrine for the stimulants, just using the common trade names. Strattera and now Qelbree and TENEX, KAPVAY and INTUNIV are the classics of the alpha-2 adrenergics. So of the stimulants, we have methylphenidate group, typically Ritalin, dexmethylphenidate, Focalin, dextroamphetamine, which is the other arm, the amphetamine side of the stimulants, which has multiple different preparations. There's also amphetamine, which is different than dextroamphetamine, Avikio, mixed salts of amphetamine, which is the name for Adderall. And just that these are the safest, most effective medicines to treat ADHD. Decades of use. Yeah, they do have side effects. You can get anorexia and sleep problems. Some people get tics on them, but they're by and large extremely safe because of the long history of use with nobody demonstrated any significant problems, well tolerated. The way they work is they release dopamine from presynaptic. So when you're in the brain, you've got synapses, presynaptic neurons, postsynaptic neurons, and it releases the dopamine from the presynaptic terminal to go across the synapse to stimulate the postsynaptic terminal. This is both methylphenidate and dextroamphetamine. L-amphetamine, which is different from dextroamphetamine, releases norepinephrine and dopamine together. That may explain why some kids do better with the mixed amphetamine salts, which includes Adderall, now even Avikio, because it includes the L-amphetamine. But it's not to say they're better, it's just we see different responses with different kids. Just briefly, these are the stimulant preparations, the methylphenidates. There's a lot of trade names now. It's all methylphenidate, so they're all the same in many ways. There's just different pharmacokinetics, how they dissolve and how they're released, but it's the same chemical. When it gets to the brain, it's the same thing. How fast it gets to the brain may be relevant, and that's different, but there still are all versions of methylphenidate or dexmethylphenidate for Focalin. And then there's the amphetamine derivatives, the short actings with that Avikio I mentioned, Adderall, there's the liquid Procentra, and then long actings, there's several, which this may not be exhaustive anymore as they keep coming out with more. Now, the mixed amphetamine salts includes Adderall and Mydayis. That has 25% each of amphetamine aspartate, amphetamine sulfate, dextroamphetamine saccharate, and dextroamphetamine sulfate. The relevance I want to point out here is that dextroamphetamine sulfate is what's in Dexedrine and is essentially what's part of Vyvanse. These are different, these other 3 salts, and We'll get into what makes them a little bit different. It's the enantiomers. So you see these two chemical structures. They look different at first glance, but look at them closely and they're just mirror images. They're exactly the same chemical, but mirror images. This is how we get the D and the L in these drugs. D stands for dextro, right rotation, L is levo or left rotation if these were three-dimensional. The relevance of that rotation is how it fits into a receptor. And so if you've got the wrong rotation, it doesn't hit the receptors properly. And so it's very unclear what these enantiomers are doing, because we know that Ritalin, it's the D enantiomer, which is in Focalin, which seems to be most active. And with amphetamine, it's also the D one for dextroamphetamine. So what is the L doing? We don't know, but these drugs have different versions of it and they have different effects on kids. So we're assuming there's something's going on. Okay, then there's the alpha adrenergic agonists. Clonidine or CATAPRES and KAPVAY, and guanfacine, the short-acting TENEX or long-acting INTUNIV. These are actually the exact opposite of stimulants. And if you remember from pharmacology, the alpha adrenergic agonists, such as these drugs like clonidine, there was an alpha adrenergic antagonist known as yohimbine that actually used to be thought of having a possible aphrodisiac effect. But that aside, that drug increases the amount of norepinephrine in the synaptic cleft, while this is decreasing it. You're actually slowing it down. This shouldn't work when you think about how it's working. Yohimbine should be working, but these do seem to work, and it seems to be for mechanisms we don't entirely understand. But it may be that there's so many subreceptors of the alpha receptors that this is affecting some of those receptors in different ways. It's just very poorly understood. But they got FDA approval, and they do seem to be effective. I mentioned how safe the stimulants are. These tend to be pretty safe, but there is a historical fear of cardiac events combining them with stimulants. It's probably not true. We combine them all the time. Nobody's documenting too much effect. But I think there does need to be, as with stimulants, being sure nobody has pre-existing heart disease. These drugs have a risk of withdrawal hypertension. We don't see it much in kids. It's more of an adult phenomenon, but there definitely is the risk if you stop these drugs suddenly, since they are antihypertensives. That's their initial FDA approval. You can get a withdrawal rebound hypertension. Most difficult side effect with this group is the sedation, usually more so from clonidine, and that's often then therefore used for sleep more than anything else. It's probably one of the safest things we have for sleep for kids because it's very short acting and doesn't seem to be causing any problems in low doses, even at bedtime. The clonidine dosing, if you're using tablets, it can be dosed up to QID because it's got a very short half-life. Well, guanfacine is generally twice a day, maybe 3 times a day. EKG monitoring is controversial. Try to keep blood pressures above 90/60 to avoid hypotension, and heart rate should be above 60. One of the problems with these drugs is they tend to be used more often in preschool kids, not because it's recommended, not because we have evidence. I think people are fearful of stimulants, and these drugs seem to be thought of as maybe better for preschool kids. The evidence isn't there for that, but the problem with preschool kids is that their blood pressures may not be this high to begin with. So you really don't know what you're doing with their blood pressure. So it's a little bit, it's got to be very careful that you're not giving them hypertension. It is amazing how resilient kids' cardiovascular systems are, though, because they really don't seem to be having much trouble with these drugs. Okay, then the norepinephrine reuptake inhibitors. Atomoxetine came out many years ago. It's not used that much because it takes a while to get an effect. It's similar to a tricyclic antidepressant as a norepinephrine reuptake inhibitor. It actually has some effect on anxiety and depression, but Lilly, when it came out, decided to market it for ADHD. It has FDA approval for ADHD and it can work. It's just not as robust as a stimulant. We looked at that number needed to treat. I don't know the NNT for this, but I know it wouldn't be as good as 3. The interesting thing with these drugs is that they have the black box warning for suicidal ideation, just like the antidepressants, because these essentially function as antidepressants. So you've got to keep that in mind, that there is that very, very low risk that a kid could begin thinking of suicidal thoughts. I think we don't see it as often in child psychiatry because kids that come to us tend to be a little more severe. And if we wait weeks for them to get an effect, while stimulants have a virtually immediate effect, they'd be thrown out of school. So So we tend not to use it as often, I guess, but we do inherit kids on it. We sometimes use it because we have to, and it's good to have as an option. It's just not as robust. The other one that just came out is Qelbree. It's patented. It's going to be expensive. The drug company came around. They told me they've got these $20 certificates for those with insurance. For Medicaid, they've got a fail-to stimulants. For private insurance, I guess they have for a year, I think they have this $20 copay. If it's a good drug after the year, they'd be paying quite a bit. So this is going to be expensive till the patent runs out. The advantage of this over atomoxetine is that the capsule can be sprinkled and it's once a day dosing. Still has a black box warning for suicidal ideation. So do you use a long-acting or short-acting stimulant? So we went through all those stimulants, and we've got many that are capsules. You give them once in the morning, and they last all day, supposedly. And you have the short-acting stimulants that typically last up to 4 hours. One of the things I think is worth knowing is that the stimulants have their primary effect when the serum levels are rising. So in other words, you give a drug, the serum level goes up, and the therapeutic effect goes up. It's known as a dose response curve. So typically, if you give somebody Benadryl for allergy even, you give them a 25 milligram dose for the hives, and they get some response. Give them a 50 milligram dose, they get a better response. It's a dose response curve. You give them too high a dose, of course, it's toxic. You give them 25 milligrams for sleep, they might sleep. You give them 50 milligrams for sleep, they sleep better. So presumably you would think with a stimulant, you give them 10 milligrams of a Ritalin dose, they get a good effect. You give them 20 milligrams, they get a better effect. Well, it's not these drugs don't have the same dose response curve. What makes these drugs work is the level as it rises in the blood, not the peak level. So if you give somebody a stimulant, the serum level rises. It gets to a certain point, then of course it metabolizes and falls off. The ADHD effect is best while that level is rising. Once it starts falling off, you're not getting the stimulant effect. The dose response curve remains for the anorexia and the insomnia. So the higher the dose, the more they probably won't sleep, the more they probably won't eat. But in terms of the ADHD effect, it's not that peak dose, it's the rising level. Concerta came out with the manufacturer came out with the Oros method. I'm sorry, that's beat it. The Concerta group came out with that capsule, looks like a tic-tac. It's like a coated capsule, and it's got a laser drilled hole in it. And that was designed to pump out methylphenidate at a rate that kept that serum level rising for a long time. It was the perfect drug in theory for ADHD. The problem with Concerta was, even though they put immediate release effect in the coating, it tended to not act fast enough. And so it tends to be great when it works for some kids, but it may be a short duration, it may be a long time until it starts kicking in, but it may last longer. Some of the other drugs that are beaded with long-acting mechanisms have a second release essentially. And so you're basically getting a response that it's just about when it wears off, the second release comes in and you get the long-acting effect. They're great when they work. What we often see, and we may see it more in child psychiatry, we get the ones that aren't responding well to stimulants, is that the parents will say, you know, this Focalin XR works great till noon, and then it stops working. Why would that be? Only thing I can figure is that for some reason that serum level isn't rising anymore. Something about the way the release was done, it's not doing it properly. The other possibility, which has not been demonstrated, but I often wonder, is the development of tolerance. When you give a long-acting drug, it remains in the system. As I said, the ADHD effect wears off at some point, but the other effects don't. And if you give a high enough dose of a long-acting drug, and you think about the half-life, there may be a few milligrams left the next morning. So you may see no clinical effect at 4 in the morning, but that still may be affecting the brain, and the neurons may not have time to regenerate, which means they may get tolerant because it's not really working right. That's just my speculation. All we know is we do see the effect that it just doesn't work after so many hours. And oftentimes we end up resorting back to immediate release medications because we don't worry about the tolerance as much with them. And it seems like we don't have to give a double dose of a long acting, which makes little sense in theory. In practice, we do see kids sometimes getting a long acting at 8 in the morning, another one at 1. It seems to work well. They don't have side effects, but I always wonder, where is that extra stimulant going? Because it doesn't just disappear. We just know that that peak level isn't affecting the ADHD levels. So I tend to be wary of trying to give too long actings in the same day if I can avoid it. And we try to use more of the immediate release when possible. The immediate release does lead to interdose symptom reemergence. So you give the tablet at 8 o'clock, at noon, as it's wearing off, ADHD recurs. So you've got to dose it in such a way to try to minimize that interdose variation, which makes them a bit harder to use sometimes. But they are easier to titrate because tablets are much easier to double, cut in half. Capsules, you're kind of stuck with a harder time titrating them. There's also the role for a short-acting dose in the late afternoon. So you may give your XR and it may last till 4 o'clock, which is great, but then there's homework and they're not going to bed yet. So they're quite rowdy as that drug wears off. So with some severe kids, we do give an extra dose of either a third short-acting or a first short-acting after a long-acting around 3 or 4 in the afternoon. Okay, just quickly about the costs from the MTA study. This is old, but still, the treatment costs varied by a factor of 4. Medication management being the lowest cost. Now, this has changed some, I suspect, because we're finding all kinds of odd things with these medications. Dextroamphetamine or methamphetamine, which is rocking the trade name now, but we actually can prescribe methamphetamine, which is a legal stimulant. It's very similar to dextroamphetamine. It's just very expensive. It comes in a tablet because it's not used very much. So the drug company, I guess, it's just not one that's used. Often Medicaid won't cover it very easily. But some of these other ones, like even dextroamphetamine, the reason we can't buy Sudafed over the counter easily is because we can get the Sudafed, use it in our basement, and come up with crystal meth. So it's very easy to make these drugs. Dextroamphetamine should cost pennies, but it's become expensive for reasons I don't understand. So it may cost out of pocket $100 for a 30-day supply, which should probably cost $10. So the pharmaceutical industry is doing funny things with the way these drugs are being produced, and shortages are created, and some of them are expensive. But typically, non-patented medications shouldn't be very expensive. These aren't that hard to make. Clearly, CLONIDINE treatment was the most expensive because therapy isn't inexpensive. It may be the most cost-effective, however, to do combined treatment because of the presence of comorbidities that need treatment. So it depends on what's going on to decide what makes the most sense from a cost standpoint. Is there a best stimulant? No. Maybe you can say the best stimulant is the one that's the cheapest, but the best stimulant is the one that works the best for a kid. And there's no reason, whatever you start with, whether you start with methylphenidate tablets or one of the XRs, whether you start with Focalin tablets or XRs, you start with Adderall tablets or XRs, each kid responds differently. So there's no prediction who responds to which. So it's whichever one works. Most will respond well to the first when you try, but there is probably a 10 or 20% chance that they won't, and you move on to the next stimulant once you've got the diagnosis. So what makes treatment more expensive is when you use stimulant alternatives first line. The other drugs tend to be more expensive rather than using a stimulant. Testing for the diagnosis. You don't need to make it, there's no test. So if you get tested, you're just costing more if you get the diagnosis. Play therapy doesn't have much of a role in treating ADHD in a therapy setting. So that's just an expensive way to see the kid. I don't think it's going to make much effect in ADHD. Atypical antipsychotic medication. At one point, these were really expensive. Again, things are getting off patent, but still, Abilify at one point was $11 a tablet. These are not first line. And one thing that we have found is that kids get aggressive with ADHD. And a lot of times the aggression occurs when the medicine wears off or first thing in the morning. But actually, what's been found is that in the large majority of these kids, treating the ADHD is the best way to treat the aggression and not adding an antipsychotic right away. There may be a role for that at some point, but it needs to be down the line. And of course, comorbidity does increase the cost of treatment. So starting a stimulant, get a baseline rating scale. So these aren't diagnostic, but they're good to know where the kid is functioning to begin with. And then we may consider immediate release for the very young child to titrate it. Maybe in later age kids, it's easier to start with a long-acting medication because of the problems getting it in school. But that's a personal choice that leaves it up to parents often as to what they want to do, letting them know the plus and minuses of each. I want to make sure that they understand that if they start a new drug and it's a 12-hour duration, they got to be sure they can handle an adverse effect for 12 hours. because sometimes these kids get really irritable and upset on them, especially the young ones. I tend to avoid using long-actings in the preschoolers or in the young kids, 5 or 6 years old, because of that adverse effect, and they hate to have it last a long time. The starting doses are harder now to talk about because of these long-acting medicines. The classic textbook dose when we had short-actings, we still do, but the classic was 0.3 milligrams per kilogram. The problem was the literature never talked about whether that was per dose or per day. And I think there's more consensus now, despite people looking at it per day. It made no sense to do it per day because the drugs aren't additive. When you give a morning dose of a short-acting Ritalin, it's gone by noon. So why are we worrying about what was given in the morning? So we tend to think of it more as a 0.3 milligram per kilogram per dose, and probably not higher than about 10 milligrams per dose in an older child. Eventually, maybe getting to 20. Follow the response every few weeks. So the dosing tends to go from 0.3 per dose to a milligram per kilogram per dose, then going up to maybe 20 to 30 max. It doesn't work though when you start getting older kids. The milligram per kilogram dosing is much more useful when you have young kids. When you have somebody who's in high school, you're not going to dose per kilogram. And so it becomes harder, I think, and you end up using more of the common sense dosing. And again, remember that it might need to be TID or long-acting plus a short-acting. So remember that in choosing a stimulant, the dextroamphetamine and mixed salts, these two of the amphetamine side are twice as potent. So if you're using 10 milligrams of methylphenidate, you're really just using 5 milligrams of these to get a similar effect. Similar to Focalin or dexmethylphenidate, which is twice as potent as Ritalin. So Metadate CD 20 is like methylphenidate 10 milligrams BID, just to think about a conversion. Adderall XR 20 is like 10 milligrams twice a day, and maybe sort of like dextroamphetamine 10 milligrams twice a day. Adderall maybe being a little less potent than dextroamphetamine. The Vyvanse conversion is complicated because it doesn't make intuitive sense given the way Vyvanse is put together. So the conversion from Adderall is Adderall XR 10 is a 30, Adderall XR 20 is a 50, Adderall XR 30 is a 70. Just as a rough idea of how to convert these drugs. One of the things to think about pharmacokinetically, thinking about the methylphenidates, for example, Concerta, I told you, has a very slow onset, may cause problems on the bus and may last the longest. Metadate has a rate of rise that's faster than Concerta, kind of intermediate onset. So it may not be quite as long acting as Concerta, but it will probably work faster. Ritalin LA, another one of the versions, much faster onset, but then the duration may be shorter. So there is a variation in these long actings based on how they're absorbed and so how long they're going to last and how fast they're going to act. They keep coming out with new ones, and it's hard to find out how they absorb. So it takes a little bit of research to look that up, but just to be aware that these differences do exist. Giving them, assuming there's no significant side effects, they need to be given 7 days a year, 52 weeks per year, because ADHD doesn't go away. It affects the kid's self-esteem, it affects how they play with peers, it affects family relationships. And if you basically give it to them in school and say, let it, play outside on the weekends, they're not going to do well. Maybe the milder cases, maybe if you have evidence, the parents say that the kid is doing fine, it's a milder case, you can get away with it. But in more severe ADHD, it really needs to be given regularly. We increase doses when the scales that we're following show this persistent symptoms. Switch stimulants when there's intolerable side effects or poor efficacy at higher doses. Remember, every preparation can give different responses and side effects. It's remarkable how you can give somebody 10 milligrams of Ritalin and they can say they're not eating well. You give them 5 milligrams of Focalin and they eat just fine, when we think that should be exactly the same kind of dose. It should be the same drug, essentially. Even when you go to something like Concerta versus Metadate, 2 long-acting versions, kid may respond well to Concerta and not to Metadate or vice versa, even not just to response to ADHD, but in terms of anorexia, tics, all the side effects can vary preparation to preparation. So it's really quite unique how these drugs are so different among themselves. And then some final considerations. Stimulants are the most effective treatments to date. The patented meds, most of them are long-acting, are very expensive. The inexpensive short-acting stimulants are inconvenient but remain an option. Avoid atypical antipsychotic meds first line. Long-term stimulant benefits are implied but not proven. And what that means is that we seem to think that giving these kids stimulants affects their long-term outcome. We don't know that with the studies yet. It's intuitive to think if you do well as a child, and you're doing well in school, you're better as an adult. And some have suggested that they aren't better as an adult, despite being treated as a child, which is odd. And my thoughts on that is that the kids probably weren't treated well enough as a child, if that's happening, but we don't know. And finally, here's a website, ADHDmedicationguide.com, which is through Northwell Health on Long Island. It's open to the public to just get this guide, which is fantastic. It has all the stimulants in color pictures, and you can get conversion rates by the way it's put on the guide. So if you want to learn about every medication we use for the stimulants, that's a great guide.